So I'll call upon Dr. Soham. He will be speaking on indication, case selection of Dmek.
Good afternoon, everyone, and thank you, sir, for including me in this instruction course. So I'm Soham. I'll be talking about the indication and case selection for Dmek and basically some practical pointers on how to choose between your Dmek versus DSEK patients. So broadly speaking, any cornea where there is an endothelial dysfunction is a good candidate for these endothelial keratoplasty procedures. So the commonest scenario that we see in our country is pseudophakic corneal edema and rarely some of the aphakic corneal edemas as well. And here we have to be, this is mostly if you're doing it in early stage, these are good patients to start off your Dmek cases with. And there can be some variations like where this is a very long standing, where there is a lot of epithelial hypertrophy. You might feel that Dmek is not possible, but if you look at the AIOS2025 and you see a picture like this, where there is a huge stack of thick epithelium, you can just peel it off and then the visibility improves and then you can go ahead with your EK procedure. This can be done either on a same sitting or as a staged procedure as well. Then this is a little bit challenging following TAS because there is more chances of fibrin and bleeding and there is a huge chance of developing glaucoma postoperatively. This is relatively less. Although the surgical part is similar, postoperative management is quite challenging in TAS situations. Next is with ACIOL. These are some of the older patients who have been operated back in the 80s and 90s where the ACIOL is present. So here you can do a two kind of thought processes. If they have enjoyed a good vision with that ACIOL for a long period of time, then probably the ACIOL is not touching the cornea as much. Then you can go ahead and do only the EK procedure. If the cornea decompensated very quickly after the cataract surgery, then better to exchange the IOL either with a scleral fixated or a retroiris claw fixated. Both give very good outcomes. So these are some of the outcomes that we have had. This is 2 years post-op and look at how well the graft has been doing. So if in the AIOS2025, the ACIOL is sitting very far away from the corneal endothelium. Fuchs endothelial corneal dystrophy. So in the eastern part of the country, we see a lot of Fuchs. Almost 40% of our patients are either Fuchs or PBK due to missed Fuchs. So these are again very good indications for either an EK or an EK triple procedure. And then this is slightly beyond the scope of this course, but again, whether you have to do a cataract only or EK later stage versus a combined procedure, that becomes a little bit of a debate and a thought process. Then this is another thing. So many of us have been doing a lot of PKs and DSEKs. So once they fail, especially for DSEK, once they fail, they can be easily taken up as a Dmek procedure patients and they do quite well because usually the posterior cornea is quite regular. In post PK, we have to take care how the anatomy of the posterior corneal curvature is. If it's a larger graft with a very regular posterior surface, then Dmek can be done quite well, then because the graft will tend to stick better. Otherwise, we can go back to the DSEK procedures. So again, anterior segment OCT is a very good tool to help in choosing which procedure for which kind of failed graft. So again, therapeutic PKs, these are slightly better candidates than optical PKs because they tend to be larger grafts. So again, so then your graft placement, centering, everything becomes easier. Post-trab tube or any of these glaucoma patients, the challenge here is basically how to get a good air fill because air will tend to seep out of either the tube or the trabeculectomy opening. So that is to be taken care of. Second, sometimes you might have to do a little bit tube trimming if it interferes with your graft unfolding. Other rare indications would be the posterior polymorphous corneal dystrophy, the congenital group, the aphakic group. The eye syndromes, we have a big percentage of endothelial dysfunction due to repeated herpes endothelitis and rarely due to CMV endothelitis and sometimes due to post-traumatic cases. So depending on the anatomy of these, so they can either be very easy to challenging. Usually eyes cases are quite challenging. CHED may have very difficulty in viewing. ABK, it's difficult to get a good air fill. HSV, usually the surgical part is not difficult, but post-operative management becomes challenging. So these are some images showing how they have been doing. So contraindications for beginners would be aphakic cases with say vitreous in the anterior chamber. If you have been expert, you can do a vitrectomy, put in a secondary IOL and then go ahead with the EK, but as a beginner, better to avoid these cases. Then where the IOL is unstable, where the visibility is extremely poor, or sometimes there can be deep vascularization. So in these cases, these are candidates for PK. These are not even candidates for DSEC. So if we look at the indications, how it differs from the Western world versus India. So mostly in the Western world, it's primarily fuchs dystrophy, followed by post-operative post-cataract edema, and followed by the graft failure cases. Whereas in India, it's primarily the post-cataract edema. However, in eastern part of the country, as I was mentioning, we have a huge percentage of the fuchs dystrophy cases. Now coming to workup and preoperative evaluation. So these, whenever you are starting out, it's very important to keep like a logbook or an Excel sheet of sorts. So then you can always go back and evaluate how the patients did. And then initially, this will also help in introspection and reviewing your own data so that you can improve over time. So this is roughly a sort of an Excel sheet that you can keep. And if you're planning eventual presentation and publication, this will help in easier data compilations. So basically, again, to reiterate, the diagnosis, the visual acuity, and the diagnosis of the other eye, because often the gut data or frank fuchs dystrophy is missed by the cataract surgeon. Then lens status and lens stability is important. Look at prior glaucoma surgery. If you can have telltale signs, sometimes not visible, you can do an ultrasound and look at how the optic nerve head shadow is looking. Intraocular pressure, applanation tonometry may not be possible. You have to rely on our fingers or some of the newer tonometry devices. Ask very good history taking, because sometimes patient may have lost the documents, so they might remember, okay, I was operated twice or thrice in this eye, so then you know that's a very complicated situation. Either they have had multiple IOL exchanges or a vitrectomy procedure before. Then the other thing to look at is the pupil, the shape, size, position, and how much is pupillary dilatation. In TAS cases, sometimes they might have a permanently dilated pupil, which initially can interfere with the graft unfolding. Then whether yak capsulotomy, this is again a challenging situation because sometimes air tends to leak behind, or if the IOL is unstable, the graft can also drop behind through that yak cap opening. Ultrasound B-scan, usually this is the go-to tool for evaluating the posterior segment. Sometimes in early cases, a macular OCT or an RNFL OCT is possible. So always attempt that, because that gives you a much better picture than an ultrasound B-scan. Axial length or biometry for both the eyes if you're doing triple procedures. Then for documentation, anterior segment photography. AIOS-OCT, as I was discussing, this is probably the most important tool for deciding whether Dmek, DSEC, and how to plan your surgery. And some of the newer AIOS-OCT gives like a very nice full field image with almost going till the lens also in terms of the anterior posterior depth. Then usually all these procedures are done under local anesthesia. In some uncooperative or challenging patients, you might have to resort to general anesthesia. And macular OCT definitely if it is possible. Then phakic patients, normally what we follow in our practice is anyone who has crossed 40, we usually do a triple procedure, because again, planning a cataract surgery under a graft is a challenge by itself. And then this, as a triple procedure, it becomes much more controlled for the corneal procedure surgeon. In situations like in eye syndrome or say in HSV endotheliitis, where you do not want to irritate the eye over and over again, it's always better to go for a triple procedure. And in younger patients, say in CHED or very young fuchs, if you have done only an EK, then later on cataract surgery can be done, but you have to take care about the protecting the graft from the surgical manipulations. So phakic Dmek, and if you're doing a triple procedure, so the IOL of choice is definitely a hydrophobic acrylic. Usually we prefer a white lens. So because yellow lenses will cause some contrast dip, and many times these patients have some corneal haze, which will compound the effect. Definitely no to multifocal IOLs. Toric IOLs can definitely be considered if there is a very high degree of astigmatism. Low degree astigmatism in presence of the corneal edema, it's not very well to measure. And always target a myopia of 0.5 to 0.75 to compensate for the hyperopic shift that a corneal edema causes. The other workup part would be specular microscopy of the other eye, just to have a supportive diagnosis of undiagnosed fuchs versus a normal looking eye. And with that, I end my talk. Thank you very much.
Thank you, Soham. So, Revati, will you add anything? Any question? We'll take the question later on
Yeah.
if you want to add anything.
Nothing much. Actually, since the course is mentioned as for beginners, so be careful about what some of the indications what Soham mentioned when you are going for, if you are starting, better wait, consolidate your procedure and then go for complicated cases.